Good afternoon, everyone. My name is Glynis Gittins, and I'm the Guideline Development Project Coordinator here at the Registered Nurses Association of Ontario. First of all, we just want to thank you all for joining the webinar today. We hope that you can all hear us clearly and you can see our slides. Just to let you know that this is a webinar type Zoom meeting, so we won't be able to actually see you by video or hear you speak. However, there is a chat box available where you can ask any questions throughout the webinar, and we will be addressing those at the end of the presentation. Please ensure that when you're writing something in the chat box that you use the all participants option. First off, I'm just going to pass it over now to Deborah for land acknowledgements and introductions.
Thank you, Glynis. We acknowledge that the office of the RNAO is located on the traditional and unceded territory of the Huron-Wendat, Haudenosaunee, and most recently, the territory of the Mississaugas of the Credit. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. This land is still home to many First Nations, Inuit, and Métis peoples from across Turtle Island, and we are grateful to have the opportunity to work on this territory. By making a land acknowledgement, we are taking part in an act of reconciliation, honoring the land and Indigenous heritage, which dates back over 10,000 years. We encourage you to learn about the land you reside on and the treaties that are attached to it. Land acknowledgements are an act of reconciliation, and we must all do our part. So I would like to welcome everyone to today's webinar as the Registered Nurses Association of Ontario provides you with an overview of our new best practice guideline titled Promoting 2SLGBTQI+ Health Equity. 2SLGBTQI+ stands for two-spirit, lesbian, gay, bisexual, trans, queer, intersex, and is inclusive of other sexually and gender diverse communities and represented by the plus sign in the acronym. The RNAO is proud to recognize the registered nurses, nursing students, nurse practitioners, and registered practical nurses who are providing day in and day out quality care. We want to thank you all for working so hard during this pandemic in keeping the public safe and for caring for those who have become ill. Our speakers today are Sheena Howard and Dr. Elizabeth Saewyc, BPG co-chairs, and Dr. Paul-Andre Gauthier, provincial president of the Rainbow Nursing Interest Group. RNAO staff participating in this webinar today are Glynis Gittins, Guideline Development Project Coordinator, and Amy Burt and myself, Deborah Flores, both Guideline Development Methodologists here at the RNAO. The objectives of today's webinar are to describe the guideline development process, including the systematic reviews that were conducted, to highlight the guideline recommendations, and to review how to interpret and read the discussion of evidence that follows each recommendation within the BPG, and to finally provide you with an overview of resources available to support with guideline implementation. As most of you know, the RNAO is the Professional Association of Registered Nurses, Nurse Practitioners, and Nursing Students in Ontario, Canada. Since 1925, RNAO has advocated for healthy public policy, promoted excellence in nursing practice, increase nurses' contribution to shaping the healthcare system, and influence decisions that affect nurses and the public they serve. The Best Practice Guidelines program is a signature program at the RNAO, and to date we have published 49 best practice guidelines that are being actively implemented across healthcare settings. Before we get into the details of this BPG, we would like to provide some background to the Best Practice Guideline program at RNAO. The program is founded on an integrated BPG model, including guideline development, dissemination, implementation, and sustainability, as well as evaluation and monitoring. At RNAO, when we develop guidelines, our intention is to support the uptake of guidelines into practice throughout supporting dissemination and implementation. We do this through a multi-pronged approach that includes individual, organizational, and system-level strategies. Additionally, we have a robust approach to supporting monitoring and evaluation so that organizations can know what impact the guideline is having on persons, providers, organizations, and health systems. Later in this presentation, we will provide a brief overview of the evaluation and implementation supports found in the BPG. I'm now going to pass it over to our co-chair, Sheena, to tell us about our amazing expert panel.
Thanks, Dem. As mentioned, Elizabeth and I were selected as BPG co-chairs. The rest of the panel is made up of 14 inspiring individuals. The panel included diverse representation. The RNAO expert panel included persons with lived experience, and it was interprofessional in composition, comprised of individuals with knowledge and experience in clinical practice, education, research, and activism across a range of health service and academic organizations, practice areas, and sectors. These experts shared their insights on supporting and caring for 2SLGBTQI+ people across the continuum of care. For example, acute care, long-term care, rehabilitation, primary care, and in the community. I would also like to acknowledge the RNAO team that was involved in bringing this BPG to life, including guideline development, evaluation, and senior management staff members. The guideline also underwent an external review process that included 71 diverse reviewers. They represented persons with lived experience, nurses, nursing students, and other healthcare providers, as well as community advocates and researchers, and were from across Canada, as well as the United States and Spain. Reviewers represented the following domains: clinical care, nursing education, policy and research, and additionally, 32 reviewers were identified as having lived experience or as having lived experience as well as clinical experience. The purpose of this guideline is to provide evidence-based recommendations for nurses and the interprofessional team related to foundational inclusive care practices, health promotion, and healthcare for individuals within the 2SLGBTQI+ community. This includes health promotion and chronic disease prevention and management across the continuum of care, including acute care, community care, and long-term care settings. The guideline does not include recommendations on prescribing medications. In the same vein, the guideline does not include recommendations focused on acute, specialized post-surgical care for individuals who have undergone transition-related surgeries. But within the context of this BPG, we refer readers to other high-quality and evidence-based resources on this topic in the appendix. Within that defined purpose and scope, the recommendations outlined in the guideline reflect the topic areas that the expert panels prioritized based on current need for guidance in clinical practice. Each recommendation asks specific questions and identifies priority outcomes in an effort to provide specific and targeted guidance. For this guideline, the expert panel agreed upon 8 areas of priority, including communication strategies, safe spaces, risk screening, group-based interventions, education at the university or college level, and continuing education. The panel was asked to prioritize specific outcomes that could be impacted as a result of each intervention or practice area. Some prioritized common outcomes across the recommendation questions to include person experience, person safety, mental health, social support, and self-management. These recommendation questions guided the systematic reviews. I'm going to pass it over to Amy to provide an overview of the methodology used to answer these 8 questions.
Thanks, Sheena. What you see on this slide is a Prisma flowchart that indicates the rigorous process for the systematic reviews the RNAO guideline team conducted for the 8 recommendation questions Sheena outlined. Our systematic reviews were aided with the help of a health science librarian. Searches were conducted in 2018 and updated at the end of 2020. We asked 8 research questions and screened over 66,000 articles. Of these, almost 1,000 full text were examined for relevance, and finally, 203 articles were included to inform the 10 recommendations in the BPG. Our systematic reviews also follow GRADE methodology, which is a rigorous process that allows RNAO guidelines to meet international standards. GRADE stands for the Grading of Recommendations, Assessment, Development, and Evaluation, and provides a framework for specifying healthcare questions, choosing outcomes of priority and importance to people, evaluating the available evidence, and bringing together the evidence with considerations of values and preferences of persons, clinical expertise of clinicians, researchers, and educators to arrive at recommendations. Grade circle methods were also used to evaluate evidence from qualitative literature. Grade circle stands for confidence in the evidence from reviews of qualitative research. Next, I will provide an overview of how to read the components of the recommendations within the guideline and navigate this large, in-depth document. For each recommendation, you will see the recommendation box, which outlines the recommendation statement, the strength of the recommendation, and the certainty of the evidence of effects. The recommendation box is followed by the discussion of evidence for each recommendation. The discussion of evidence includes 6 components, and I will explain each of these in a little bit more detail. The first component is benefits and harms. In simple terms, this section highlights the desirable and undesirable outcomes reported in the literature when the recommended practice is used. The second component, values and preferences. It highlights the preferences for a recommendation and the value placed on the resulting health outcomes from a person's perspective. The third component, health equity. This highlights the impact the recommended practice could have on health outcomes across different populations or settings and potential barriers to implementing the recommended practice in a particular setting. The fourth component is expert panel justification of recommendation. This provides the rationale for the expert panel's decision regarding the strength of the recommendation. Specifically, this section details why the panel decided to vote the strength of the recommendation to be conditional or strong. Following the panel justification, you will see the fifth component called practice notes. This section includes pragmatic information on conducting the intervention. This information can come from the evidence as well as the expert panel. The final and sixth component of the discussion of evidence are the supporting resource, which includes relevant resources such as websites, links, tools, checklists, etc., related to the intervention. There are 10 recommendations and 1 good practice statement that fall into 5 broad categories in the BPG. Some are foundational to all practice, inclusive communication and safer spaces. Some are more clinically focused, risk assessment and screening, and group-based interventions. And the final broad category is education. I'm now going to pass it back to our co-chair Sheena to tell us more about the inclusive communication recommendations.
Thanks, Amy. There are 2 inclusive communication recommendations in the BPG. The first recommendation that we're going to focus on is recommendation 1.0 on inclusive communication. The recommendation reads, the expert panel recommends that health providers use 2SLGBTQI+ inclusive language and a person-centered history-taking approach, and ensure privacy and confidentiality during interactions with all people to be inclusive of 2SLGBTQI+ people. When health providers use these communication strategies, this may provide 2SLGBTQI+ people with a greater sense of safety and comfort. There were no harms reported in the literature. Inclusive language avoids using words, expressions, or assumptions that would unnecessarily exclude people. In particular, in the evidence reviewed, people reported feeling safe and comfortable when healthcare providers used gender-affirming language and avoided heteronormative and binary language. Participants in several studies described how they must be called by their chosen name and the correct pronoun and title, for example, Mr., Ms., or MX, in order to feel safe and comfortable during care. A person-centered approach involves advocacy, empowerment, and mutual respect, and understanding of a person's rights to be autonomous, to self-determine, and to participate in decisions about their health. Overall, persons feel comfortable and safe when health providers avoid asking questions that are not relevant to their care needs or are based on heteronormative assumptions or assumptions about a person's sexual orientation or gender identity. This was particularly evident with regard to taking a sexual health history, including sexual behaviors and relationships. While privacy and confidentiality are legislated requirements of health provider practice and health service organizations, They play a particularly vital role in providing care to the 2SLGBTQI+ community. Strategies for providing care with enhanced privacy and confidentiality in your practice, and that emerged from the evidence and includes being open and explicit with provisions for maintaining privacy and confidentiality, spending time during the first visit or visits to establish confidentiality, allowing people to opt out of data collection or data storage, and being vigilant in physical environments where conversations are not private or could be overheard, such as the emergency room or waiting room. There is a related appendix that supports this recommendation. It can be found in Appendix I. I always want to use a number. Or is it 1? Sorry. Amy, can you tell me?
It's I. It's I.
It's I. Okay, thank you. Excuse my academic confusion. Such as the chart on our examples of inclusive pronouns. The second component is values and preferences, and it highlights preferences for a recommendation. Oh, my goodness, reading the wrong one. How embarrassing. The second inclusive communication recommendation reads, the expert panel recommends that health service organizations implement 2SLGBTQ+ inclusive signage, forms, and documentation. So those of us who have known this for a great length of time, it's exciting to have this recommendation be validated. Inclusive signage includes symbols, signs, posters, and other visual messaging that help to signal to people that the health service organization will be a safe and welcoming environment. Examples of such signage include the rainbow flag, the trans flag, or other safe space symbols, including signage that can include physical or written materials as well as digital signage. The evidence highlights how these communication strategies may provide 2SLGBTQI+ people with a greater sense of safety and comfort. There were no harms identified in the literature. The expert panel cautioned against signage in the absence of appropriate implementation of a safe space and underlying processes, including training of all staff that interact with people. Signage could be harmful if some staff are not prepared to interact in an affirming way with people. The following areas of forms may need to be adjusted in order to be inclusive: sexual orientation, gender identity, sexual history, relationships, reproduction, and privacy. Also for recommendation 1.1, there are related appendices that support this recommendation, including Appendix J, examples of inclusive symbols and flags, and Appendix M, an example of an inclusive form. I'm now going to pass it over to my colleague and co-chair to tell us about the safer space recommendations.
Thank you, Sheena. There are 2 recommendations for safer spaces, one for health service organizations and the other for schools. Recommendation 2.0 reads, the expert panel recommends health service organizations create safer spaces for 2SLGBTQI+ people through a multi-component approach. The expert panel chose to use the term safer spaces in the recommendation statement to highlight the need for health service organizations to continuously assess, improve, and enhance the safety of the organization. The expert panel cautions that a truly safe space is rare, and the use of the term safer space acknowledges this. The evidence suggests that safer spaces in health service organizations may improve reported outcomes of perceived safety, experience, return of persons, and representation. However, the evidence is uncertain. A multi-component approach where at least 2 of the following methods were used to establish safer spaces included an anti-discrimination policy, diverse representation of staff, inclusive intake forms, 2SLGBTQI+ events, referrals to support, and written materials and signs. 3 additional components of a safer space can include dignified and respectful access to trans and non-binary inclusive bathrooms, a complaints and public relations department that has clear channels to address complaints and to ensure public relations or complaint teams are knowledgeable about 2SLGBTQI+ issues and barriers to care, health settings who provide counseling services or other settings with a long-term person-provider relationship can provide a list of staff members who have knowledge, skills, and comfort in working with different 2SLGBTQI+ populations. A few studies in the literature were specifically focused on older adults in safer spaces. Older adults residing in long-term care reported the need to feel safe, accepted, and the wish to be themselves. Seniors were attracted to the comfort and ease of their LGBT-focused environment, where there was a perception of safety, the removal of negativity, and living out of the closet. Refer to the BPG for further considerations for older adults. The recommendation 2.1 reads, the expert panel recommends schools create safer spaces for students that include gender sexuality alliances, or GSAs. A safe space in schools is one in which everyone, students, staff, and parents, feel welcome, safe, and respected. Gender sexuality alliances, or GSAs, are school clubs in which students can talk and learn about sexual orientation and gender identity. They're structured like any other school group, with a faculty advisor and regular meetings. Everyone is welcome. Two-spirit, lesbian, gay, bisexual, trans, queer, and questioning students, as well as heterosexual and cisgender students, students with 2SLGBTQI families, and students who do not have or need a label for their sexual orientation or gender identities. A GSA is a more inclusive name than the term gay-straight alliance, which may also be used, and that's where GSA further came from. The expert panel chose to use the term safer spaces in this recommendation as well. The evidence suggests safer spaces in schools may increase reported outcomes of perceived safety, return of students, and student experience, and no harms were reported in the literature. The most common component of a safer space is in the school environment, GSAs. Other components of school-based safer spaces included anti-discrimination or anti-bullying policies, gender-neutral bathrooms or locker rooms, inclusive signage, and the importance of educators and professional development. Nurses working in schools, public health, primary health care, and community care can play an integral role in advocating for safer spaces in schools. In most studies, GSA presence alone was enough to confer benefits to all students, regardless of whether the students were members of the GSA. Next, I'll pass it over to Amy and Deborah to tell us about the risk assessment and screening recommendations of the BPG.
Thanks so much for that great summary, Elizabeth. So there are 2 recommendations and 1 good practice statement in this category. In addition to the recommendations, this guideline includes 1 good practice statement. So a good practice statement refers to a practice that is already accepted as beneficial or practical and provides context to subsequent recommendations in the guideline. The good practice statement is believed to be beneficial, and conducting a systematic review to prove its efficacy would not be necessary. The resulting statement is not based on a systematic review, and therefore it doesn't receive a rating of the certainty or confidence in the evidence, or the strength, strong or conditional. This good practice statement also provides context for the subsequent intervention recommendations you will see on the coming slides. So the good practice statement reads, the expert panel recommends that health providers assess 2SLGBTQI+ people for factors that may place them at an increased risk of particular health conditions. Health providers are to follow established screening guidelines as available and based on a person's current anatomy. Accompanying this good practice statement, we have included a detailed chart outlining the evidence and any relevant screening guidelines for specific conditions, including cancer, chronic disease, mental health, and sexual health. We have also included a quality rating for each guideline that we refer to. Critical practice notes in this area include to be aware of the gendered or binary language used for screening, particularly for many cancers. Use inclusive language instead. For example, use chest or upper body instead of breast, or simply name the involved organ instead of saying female reproductive cancer or male reproductive cancer. Screening and assessment also needs to be delivered in a safe, sensitive, respectful, and affirming manner. And this should be in alignment with recommendations 1.0 and 1.1 on communication strategies we heard about earlier. And it should also be in line with RNAO's person and family-centered care principles. Next, I'm going to pass it over to Deborah.
Thank you, Amy. The first recommendation in this section is 3.0. Addresses cervical cancer screening and reads, the expert panel recommends health providers ensure the comfort and safety of lesbian and bisexual women and trans and non-binary people during cervical cancer screening. Health provider communication style and demeanor is critically important. Ensuring a comforting and safe experience involves health providers not making heteronormative assumptions about women's sexual orientation. Completing comprehensive, non-judgmental sexual histories would help facilitate sexual orientation disclosure so that women are not burdened with having to reveal their sexual orientation or correct providers' heteronormative assumptions. Qualitative evidence suggests that ensuring the comfort and safety of lesbian and bisexual women, as well as trans and non-binary people, during cervical cancer screening may support positive experiences of care where persons feel safe. Transmasculine people appreciated health providers who were willing to modify the cervical cancer screening exam. Possible modifications included allowing persons to self-insert the speculum, prescribing anti-anxiety medication, instructing them on how to perform exams at home with a partner, and performing HPV tests to inform the need for speculum examination. Amy will now outline the second recommendation.
Thanks, Deborah. Recommendation 3.1 reads, the expert panel suggests health providers promote access to HIV/STBBI screening for 2SLGBTQI+ people in collaboration with 2SLGBTQI+ community partners through media campaigns and/or outreach settings. The literature suggests that media campaigns and outreach programs that are developed in collaboration with community partners may increase the number of people who access HIV/STBBI screening. In one study, participants reported the risk of further stigmatization, and this study was in Black and Latino youth specifically. So there was a risk of further stigmatization of those youth during media campaigns. This recommendation focuses on media campaigns, screening at 2SLGBTQI+ special events, and outreach settings for those who are not already accessing HIV/STBBI screening, and for any 2SLGBTQI+ people who may be hard to reach. HIV/STBBI screening needs to be accessible and available to all people. To normalize screening, it's important to include images of heterosexual couples, in addition to lesbian or gay couples in media campaigns. I'm now going to pass it over to Sheena.
Thank you, Amy. The next two recommendations we are going to focus on are about group-based interventions. Recommendation 4.0 reads, the expert panel suggests health service organizations implement specialized 2SLGBTQI+ clinical groups for health promotion and chronic disease prevention and management. Clinical groups for health conditions are group-based interventions focused specifically on the management of health conditions, for example, diabetes or anxiety, or prevention and/or management for behavioral risk factors for chronic diseases, such as tobacco cessation and weight loss. Clinical groups may improve outcomes such as feelings of social support, improved care practices, and enhanced self-efficacy, but the evidence is uncertain. Some of the key similarities of group-based interventions in the evidence were stakeholder and community involvement in the design, empowerment-based approach, empowering clients that is based on the premise that people have the right to make their own choices and decisions around their own health. The use of peer facilitators in the delivery of the interventions, opportunity for group discussion, and the delivery was typically multi-session, and a variety of approaches to delivery were used, including in-person, online, social networking, and telephone. Key practice notes include maintaining privacy and confidentiality, regardless of group membership, and promoting other clinical groups along with 2SLGBTQI+ groups to avoid stigmatization and exclusion. Recommendation 4.1 reads, the expert panel recommends health service organizations implement group-based interventions for 2SLGBTQI+ people addressing the social determinants of health. These group-based interventions should be inclusive of and promote access to underserved 2SLGBTQI+ people, including Two-Spirit, Black, Indigenous, and people of color, older adults, youth, migrants, and people with disabilities. Group-based interventions may include support groups, but may also include complex group interventions such as coping skills, education, or counseling. Evidence suggests that persons who participate in tailored group-based interventions may experience improved social support and improved self-care, and may report positive program experiences and a greater acceptance from peers. However, the evidence is uncertain. Some commonalities of the group-based interventions in the evidence include a focus on providing a safe space, empowerment-based approach, peer or ally-led facilitation, time for group discussion, tailored education or skills-based content. For example, several of the group-based interventions including coping skills, training, or development. Another consideration in offering group-based intervention virtually and by telephone may improve access for persons living in rural areas or those who, for whatever reason, are unable to participate in person. Next, I'm going to pass it over to Elizabeth.
Thank you, Sheena. And as a professor, finally, I'm going to walk us through two education recommendations that are definitely those nearest to my heart. Recommendation 5.0 reads, the expert panel recommends academic institutions integrate affirming 2SLGBTQI+ health content into curricula for all students entering health professions. Evidence suggests that integrating health content into curricula may improve their knowledge, skill, and experience. The expert panel felt it was important to include affirming health content as much of the existing health content is cisnormative and heteronormative and can be stigmatizing or pathologizing. Affirming health content is supportive and accepting of 2SLGBTQI+ people and communities. Some practice notes for the from the expert panel include, the expert panel stated that education is to be compulsory and this content must not be optional. Education content is to align with overarching frameworks of intersectionality, anti-oppression, and decolonization. Health content should be reviewed by 2SLGBTQI+ content experts and 2SLGBTQI+ persons to mitigate potential for harm. This content should be regularly reassessed to ensure all information, including language and terminology, is relevant and up to date. Many more detailed practice notes are available in the BPG on pages 97 to 101, including strategies to integrating affirming 2SLGBTQI+ health content throughout the curriculum, the role of faculty and staff, and details on the content and delivery of education that are examined in the evidence. Recommendation 5.1 reads, the expert panel recommends that health service organizations provide affirming 2SLGBTQI+ continuing education for all health providers. For this recommendation as well, the expert panel felt it was important to include affirming health content explicitly. The majority of studies included content on cultural safety and clinical competence. Evidence suggests continuing education may increase health provider knowledge and lead to practice change. However, the evidence for the outcome of practice change is uncertain. In qualitative studies, participants in education programs reported positive change in practice through experiencing comfort with lesbian, gay, bisexual, and trans persons accessing services, and an increased ability to provide non-discriminatory, respectful care. Participants also reported improved knowledge. No harms were reported in 35 of the 36 studies included. Critical practice notes in this area include continuing education is offered to all health providers and that staff that interact with persons, and it's tailored to their specific role. Continuing education needs to be ongoing and supported by organizational leadership and embedded in organization processes, policies, and culture through orientation, annual education, performance appraisals, and supervisor support and consultation. Practicing cultural safety requires all health providers and staff to be reflective and to understand their privilege and biases. Detailed practice notes, including continuing education content and delivery, are detailed on pages 108 through 112. Next, I'm going to pass it over to Deborah for some wrap-up items.
Thank you very much, Elizabeth. Additional content in the guideline includes evaluation and monitoring measures on page 18. If you are an organization implementing this BPG and want to know the impact of the recommendations on practice change or on person outcomes, you can use the measures outlined in these charts to monitor implementation success or areas that may require further change initiatives. These measures were developed with the panel and also received internal and external feedback. In addition, there are several other useful appendices relevant to the guideline as a whole. So there's a few resources that can help you implement this guideline in your practice if you wish. We encourage you to read the guideline, which is available for free online. I know today we did a very high-level overview of the guideline, but we hope you will take the time to read the guideline thoroughly, including some of the evidence in detail, the appendices and resources, and you may consider discussing it with a colleague or completing a gap analysis. You can also become a best practice champion through our Best Practice Champions Network. We also have a newly released resource and new edition of our implementation toolkit called the Leading Change Toolkit. This toolkit walks through the systematic and planned steps of the Knowledge to Action framework, which helps support integration of evidence-based recommendations into practice. In addition, this new toolkit, an updated toolkit, includes a social movement action framework. You may also be interested in learning more about our Best Practice Spotlight Organization, or BPSO designation program, a key organizational knowledge translation strategy which supports best practice guideline implementation, rapid learning, and evidence-based practice sustainability. We will also be publishing a 2-page plain language health education fact sheet based on this BPG this fall. The health education fact sheet may be used as a teaching or empowerment tool. If you have any questions about this guideline in the future, please contact us through the RNAO website using the Contact Us link. We would like to acknowledge the advocacy work of the Rainbow Nursing Interest Group and others who were instrumental in advocating for the need for this BPG. The mission of RNIG Rainbow is to foster and advocate for nursing practice and environments that support people of all sexual orientations and gender identities and expressions. I am now going to pass it over to Dr. Paul-Andre Gauthier to share details about a new position statement and some closing remarks.
Good afternoon, everybody. Thank you so much to Sheena and Elizabeth and Brittany Grooms, who help us also developing the BPG and also the position statement. The individuals you see on the screen, they were the ones who helped us develop the new position statement. So we went from a 12-page document to a 2-page. And you can find also this document in the BPG that is attached. So we try to summarize also the LGBT perspective and looking at the prejudice, stereotypes, and discrimination that happen to our community. So I think for some people who are not familiar, you consider the 2S at the front of the LGBT plus to recognize the Truth and Reconciliation treaty that was promoted. And also the word patients, quite a few documents that were changed for people or individuals. So in order to reflect the respect that for the First Nation individuals. So when you will look at the position statement, you will find that we have a section on violence and social exclusion, also access to healthcare services and care, and quality and work environment, and also to speak out on human rights and health equity, and to make sure we're fostering a safe and inclusive environment for work and for us as nurses, but also with other healthcare professionals. So the intent is to give an informative summary documents to the public and also to nurses about what it is about, and for the people to in order for have quick access to what it means. So we are talking, there's another word that I like to talk about is equity and equality. This is different because we are looking at equity, equitable access. So for the LGBT, the 2S LGBT community that may not have access to the service and healthcare services as they need, we need to make sure that it is becoming equitable. We cannot talk about equality until we get access to all the services. So I would like to thank the panel members. There's quite a few people who work on that BPG, and also to the RNAO staff for helping us in the background to be able to develop this BPG and also launch it. And thank you so much for today to presenting this BPG. And I hope with the question that members may have, that we may have a second one or a third webinar on this BPG in order to familiarize the individuals. Thank you so much. And on behalf of the executive, we thank you, and we hope that this presentation today enlighten you to what we're talking about when we're looking at healthcare for the 2SLGBTQI+. Thank you. Have a good day.
So thank you very much, Paul-Andre. So now we open up the chat box for questions. If anyone would like to ask any questions, we welcome them.
I see one question in the chat box here from Rebecca. So Rebecca's asking, how can the current and future nursing curriculum reflect the new best practice guideline in relation to providing care to the 2SLGBTQI+ persons? Maybe Elizabeth, you might like to answer that question.
Yeah, sure. So I think that I think that this is actually a useful best practice guideline to advocate for integrating further content into what already, the competencies and standards in the various provinces and throughout Canada on care do include elements of person-centered care and cultural safety. And this guideline provides some evidence as well as resources and links to help educators move forward in integrating into all of the different aspects of nursing education. One of the things I've seen as the director of the School of Nursing at UBC is this challenge that people say, well, there's so much already in our curriculum. How can we possibly add anything more? And part of it is really looking at how can you actually substitute case examples? How can you ensure that when you're talking in your lectures about particular content, that you're shifting it to be inclusive of 2SLGBTQI+ people? So that may include changing your language. We have a faculty member who just completed a textbook on breastfeeding as part of the content, and they're sort of internationally the ICBLC certification, and actually asked for some consultation within our school and with experts, 2SLGBTQI+ experts throughout, about shifting the language within the textbook to be inclusive of trans fathers who are chest feeding, in addition to the variety of other people who may be providing nutrition to newborns. And that ability to think about how we use the language, how we use examples, how we recognize some of those ways that health may be the same and different for different groups becomes important as part of the integrating that into the curriculum. And in doing so, you end up actually not, you expand the content and curriculum without expanding the time needed. So that's an important consideration, is where you actually change language and examples and exam questions and further, readings and resources throughout the curriculum to actually be inclusive. And part of that then adds that sort of the destigmatization by integrating it throughout, rather than saying we're just going to have a section here. You are also normalizing that affirming language in practice as well as in education.
Thanks, Elizabeth. There's a question here about pronouns. So Shania is asking, what pronouns should I use if I'm unsure? Is it appropriate to ask? I don't know whether maybe Sheena or Elizabeth want to tackle that one.
Well, I can answer maybe that one.
Sure.
I think we should ask the person, how do you want to be referred to, as a he or him, her or she? Tell us, or they, and that's the best way of doing it. And I understand that when doing some work with the LGBT community, sometimes it's not easy to remember, but you can write a note on the top of the chart or the evaluation form that they want to be referred with these pronouns. So it's much easier in that way and avoiding some mistakes.
I can add to that. I would just like to tell a quick story. When I asked an elderly gentleman about, or an elderly person about their, let me get the language right, an older adult about their pronouns, he laughed and he said, well, I'm a guy, he said, and I'm so glad you asked because my granddaughter has just transitioned. And he said, it's so good to know that if she came into this office, she'd be supported. And so when we're asking about pronouns or we're using inclusive signage or inclusive language, we're not only impacting my community, but we're in supporting my community, but we also have a great network of friends and family members, and it signals to them that you're an inclusive space. And I noticed that there was a question from, and I'm going to perhaps get this wrong, but Aestus, about exploring about this, if this work included exploring on how we can better serve polyamorous families, and if not, is it on the horizon? And it didn't include that as a topic or a section to review, but I think it would be something good to bring forward for the next revision of this BPG.
I think one of the important aspects that is both a strength and a challenge of a best practice guideline like this is that we struggled with where there wasn't research evidence. And so part of this is there is a section about what are the gaps in the research. And for those of us like me who actually also do research, it's like a blueprint for what more is needed. And certainly when it comes to polyamorous families, the research around health and healthcare is quite limited, and it just basically gives a call to action to do better and to do more.
And I'm sorry, Amy, if I can just jump in. There was one comment by Stephanie about medical schools needing to do a better job within their curriculum. And I think it's the CF, one of the physician journals last month came out with an opinion piece about that exact thing, that indeed they needed to do a better job at it. I'd like to point out that it's the nurses who did it first.
Okay, so maybe I'll just go in order. So a question from Rebecca: will there be workplaces such as hospitals that develop their own policy in relation to caring or becoming familiar with caring for 2SLGBTQI+ persons?
And the answer to that is there are many workplaces that already are. This is an opportunity, if those policies aren't actually made explicit in your healthcare setting, you can bring the best practice guidelines to provide evidence that these policies are useful, that they don't cause harm, they actually may improve access to care and health outcomes, and these are some of the things that they can actually take up. I know that part of some of the communication that we've had with different health organizations as this work has been ongoing and they've heard that we're developing a best practice guideline is, oh, good, we need this, because evidence is often what's needed to move health organizations to do the right thing. And so being able to provide this information to either affirm that what they're already doing is in the right direction, or to help further spur change. But as was described, the best practice guidelines really do benefit from having champions who take them up in their organization.
So the next question is, what can we do when the name and gender on a patient's health record do not match?
So if the issue is that the health record still has a legal name, and the legal name hasn't changed to align with people's gender identity. And I know for young people, I do a lot of research with youth, and oftentimes they have extra delays in being able to change their names or to be able to shift aspects of like their IDs and records so that the gender on those actually aligns with their gender identity. It is really important that organizations have the opportunity to include preferred names and identify gender, not just body parts or sex, on people's health records, so that if you have that preferred name and you're using that rather than the specific legal name when you're communicating, when you're actually calling people's names, etc., that creates an important message of respect and affirmation. And I know far too many people who are struggling with the systems in place to actually make some of these changes in the bureaucratic health systems. So working with IT, you know, whoever thought that IT services in a hospital are one of the important places to actually create 2SLGBTQI plus affirming care. But that is one of the places where some of this advocacy can work.
And to add, if by chance, like we all have, we've made a mistake and misgendered someone or misidentified them, the important piece here is to apologize sincerely rather than start making excuses for the reasons why you made the apology. For example, oh, I'm sorry, but your gender doesn't appear to match your name, or vice versa, but rather just an opportunity to say, I'm sorry, what are your preferred pronouns, or what's the name that you would prefer me to use?
So the next question I see here from Ruth, what has RNAO done to ensure that as an organization they are following this guideline? So thank you so much for that question. I think one of the best examples of what RNAO has done is the position statement, because RNAO has two main arms, one on evidence-based practice and one on policy. So through our position statement, we're ensuring that our policy work is also advocating for respectful, safe, and affirming environments for 2SLGBTQI plus people. Deborah, do you have anything else to add?
No, I think that's a great response, Amy. Stay tuned. Stay tuned. Well,
stay tuned. Yeah, it's very important that we stay
Yeah.
accountable as well.
Absolutely.
So I think the next one is a comment from Sandy about having name tags where the pronouns are identified as well. And Rebecca was just asking about contact information. I put my email into the chat box again. I'm happy to be the contact person for any questions that stem after this that we don't get to today.
And I know I'm happy to get those email questions forwarded from Amy, or you can see my contact information at UBC is up on the web. You're welcome to reach out.
Yeah, absolutely. I'm not a content expert myself, so I will direct them where I see fit. So a question from Stephen. I've worked with clients who were white and felt that the Two-Spirit label resonated with them and they chose to identify that way. However, I've also worked with First Nations clients who stated that this term is culturally specific and it would be an example of inappropriate cultural appropriation for anyone who isn't First Nation to use. Can you clarify what is appropriate here when engaging with clients?
That's a tricky question.
Very tricky question.
In the 1990s, early 1990s, it was the Gay and Lesbian Native Association that actually came up with the term Two-Spirit as a cross nations terminology that would be Indigenous specific. to provide a sort of opportunity to identify, because there are different terms in different languages in each of the nations, and the understanding of Two-Spirit or the specific terms within the different nations is quite variable and also and very specific. I think it's important to actually ask within the local community and paying attention to the guidance from Two-Spirit people in your local community as to how best to identify what Two-Spirit means, and also who has the right to use that label. In some places, it's actually, there are Indigenous people who won't take up that term unless an elder has assigned it to them as well, or there are spiritual ramifications for it. So it's, I don't think there's a one-size-fits-all option here, but a really important one is to actually center the voices and perspectives of Two-Spirit, Indigenous, and First Nations people.
I think we probably just have time for a couple more questions. So there might end up being some that stay in the chat that we can try to answer after the fact and send an email to that individual. Hasty's asking if there's any information in the guideline about how to deal with individuals who do not support 2SLGBTQI+ individuals to ensure everyone is safe. So I wouldn't say that this was an area that we specifically addressed. We do speak to anti-discrimination policies within the framework of our Safer Spaces recommendation. So I would say that's probably the most relevant area. Sheena or Elizabeth, do you have any other thoughts on this one?
Well, I think I'd like to assert that the entire the first recommendations that I was speaking to around safer spaces and communication are one of the ways that, and the evidence to back that up, are one of the ways to deal with individuals who don't support LGBTQ individuals. That there's a wealth of information to support that that are safer space, that in order to be considered a safe space, we need to be using those things, and that pointing to the evidence is a really good way to help keep it out of a personal frustration with the people who aren't supportive, and keep it more in an academic discussion. Elizabeth, do you have anything you might want to add to that?
Yeah, I think, it's important to remind people, perhaps, in terms of those who don't support individuals, that Canada's and all the provincials' human rights code actually prohibit discrimination on the grounds of sexual orientation and gender identity and expression. And so as a clinical healthcare setting and a healthcare provider, we are obligated to actually not discriminate against people, and ensuring that we provide culturally safe care and we're not discriminating is actually also part of our nursing code of ethics. So, part of addressing this is providing education and providing policies, and then we are back to management taking leadership and actually providing the appropriate guidance and performance management for people to ensure that people are getting the right kind of feedback on how they are or are not supporting people, and oftentimes even just how to do it. See, that's one of the challenges, is it's not enough to say, don't do that and just wag your finger, but rather, what do you do instead? Are there ways that we actually can provide some concrete guidance for people on, if you say it this way, it actually is disrespectful, but if you say it this way, it's more supportive. And so sometimes it's needing some concrete skills to help people actually develop the knowledge and the practice to enable them to provide appropriate care, even if their personal beliefs are something other that is part of our code of ethics, is that non-judgmental care that's part of nursing.
Paul-André here, I can support that definitely, because sometimes we do forget. My clinical experience when we look at individuals with the 2SLGBT community is respect is key in there. But also I would add that individuals have various levels of sensitivity. Some people don't like some terms, some people prefer other terms. Just be aware of it. Like Sheena said earlier, you say, I'm sorry, can you help me with this? Or how do you want that to be referred to you? Another comment I want to make, the last one, is about the position statement. When our executive, the 10 of us, worked on the position statement, one of the things we noticed is nothing is perfect in the 2-page document that we provided, because one of the things we know, over time, terminology will evolve and new terms will come, and then new perspective would also come in. So nothing is perfect at this time, but we certainly have 2 great documents to work from, one being the BPG and one is the position statement for our community. Thank you.
Thanks, Paul-André. So we are a couple minutes after 2 and I see our participants starting to drop off. There's just one more question, so maybe we'll try to answer that and then we'll wrap up. So Michael was asking, have you considered using the term accountable spaces rather than safer spaces, as safer can give the option of complacency? Safer than what?
It's a good point. And it's a good word. I think the challenge is that in a similar way, people don't always immediately resonate with or understand accountable as as meaning a space that is inclusive and safe and welcoming and supportive and culturally supportive. So I definitely appreciate the importance of the accountability. And of course, that also adds that extra question, accountable to whom and accountable for what, which is really key to being able to identify the spaces and how they need to change to be welcoming and supportive for everyone.
We've already got our list started for the revision from today's discussion, which is fantastic. Okay, so I think we should probably wrap up. I don't know if Sheena or Elizabeth, you wanted to say any final comments.
Just a warm thank you for attending today. And again, a warm thank you to the RNAO, to the team that has supported this BPG and has worked hard to see it off the ground, and to our expert panel. Just a very warm thank you for your time, your energy. For those of us with lived experience, a special thank you for using both your personal and your professional experience in the creation of this BPG.
Yes. Thank you. It has been a labor of love, a lot of work, and I really hope that it has the opportunity to continue to transform healthcare as we know it needs.